Hey there, everyone. Welcome back to another episode of Motivation and That, where we take hot mess to high potential. My name is Natalie. I'm your host, and I'm really excited today for a guest that I'm bringing on who is right here in my physical geographical area, but is going to be able to talk to us about a topic that I think is one that maybe we don't understand all that much, or maybe we're fascinated about learning how things have changed over time and how do we really know what makes up a clinician, a physician, how they get to where they are, and are we creating new spaces to craft those physicians moving forward? So I usually don't do a round of background on the guest, but I was really enjoying reading about your background, Dr. Rose. So let me just share a little bit with everyone else here that's listening today. Dr. Miko Rose is the founding dean of the Indiana University of Pennsylvania's proposed College of Osteopathic Medicine. So if you hear us say IUP, it means Indiana University of Pennsylvania. That's something that always, I think, trips people up when they hear Indiana and Pennsylvania. Where exactly is this?
Yeah.
But it's just outside of the Pittsburgh metro area, a little more rural than most people tend to think about being around Pittsburgh. But we'll get into that in a little bit. Dr. Rose has been named one of Pennsylvania's 50 over 50 by state and city and state Pennsylvania, meaning that she is one of the most influential leaders in government, business, and media, and those who are shaping the future of our state. Dr. Rose is a board-certified physician in psychiatry and neurology who is nationally known for wellness programming and began work as the founding dean of the IUP proposed College of Osteopathic Medicine in November of 2023. Prior to that, she worked as a program officer, fundraiser, and advocate for the underserved with a focus on overcoming domestic violence and trauma. With more than 25 years of experience and formal training and life coaching, she draws upon her experiences with the underserved communities and creates and facilitates happiness training programs for medical providers and trainees across the country. And I can't say how much I think we probably need that, right? Bedside, for a physician isn't just about how they interact with us, but how they are well themselves in so many ways. And
Yeah.
what a stressful world to be in, especially right now. So thank you so much for taking a little bit of time out today for this kind of rapid fire. Let's learn about the college. Let's learn about you. Let's learn about rural medicine and who's going to be providing that care. But Dr. Rose, what else would you like listeners to know about you and where you come from and how you ended up here right in Indiana, PA?
Well, I love that tagline, hot mess to high potential. That is just kind of brilliant. I think one of the beautiful aspects of what you're doing in this podcast with your listeners today and for your other recordings is just this piece on high potential. And that for me, I'm a first generation physician. I was not a pre-medical student as an undergraduate in the college where I did my undergraduate studies. It wasn't even on my radar. And flash forward a few decades later, I've been blessed with this incredible role to now lead a charge to look at doing something in medical education, to build something that will support the infrastructure of this statewide infrastructure of the Pashy, Pennsylvania area, like network of government-based schools, both undergraduate and graduate programs, as well as this one school in that whole network of schools, Indiana University of Pennsylvania, as well as our surrounding communities, to really set some models for rural health and rural healthcare to do things differently. So it's kind of just been an amazing journey. I'm happy to kind of pinpoint and highlight special points that might be helpful to some of our listeners, as well as just share some of the vision and pieces that we've been putting together. It's been not just me, but an incredible team of folks here at IUP and also in the Indiana and surrounding community.
Yeah. And when I was looking up a little background, schools of medicine, whether they be for medical doctors or DOs, and we'll get into that difference in a minute,
Yeah.
but they don't just spring up everywhere. This isn't something that is just we're going to create this college to create physicians. It is really hard. In 10 years, I think I saw there were maybe 15 new schools between the two that have come up, which
Yes.
is slow in a world of higher education where you kind of see even the for-profit, not-for-profit, they're all diversifying and building. But this, because there's so much that goes into it,
Yeah.
it's not just a quick snap of the fingers, right? This is a work in progress. It's going to take a couple more years to fully flush. But what has that initial kind of piece been like? So why was it a vision in the first place? And what have you learned in the first half of this kind of development?
Sure, sure. So the birth of this project as a concept and conceptualization was not started by me. I was actually hired much after the project was decided to be, if you will, like midwifed and started to be birthed. So Steve Wolf, who is president of the Indiana Regional Medical Center, as well as the Pennsylvania Mountain Healthcare Alliance of community hospitals that have in essence banded together and share resources, and I know you know that group quite well, along with President Driscoll, who is the president of Indiana University of Pennsylvania, got together with Steve Wolf, and the two of them said, look, we have a healthcare crisis and need for healthcare providers throughout rural Pennsylvania, particularly in the Indiana region. IUP and the region of Indiana had seen a great decline in enrollment in their particularly undergraduate but university enrollment across the board, and so they came together. It's kind of like the Reese's Pieces, like commercials from the 80s. Like I got peanut butter, you got chocolate, let's bring it together, and it's like this delicious snack. And they really came together and said, let's build a medical school. It was sort of an idea that initially, when they first started having discussions and looking into some of the feasibility, knowing some of the economic models, that if one could overcome a number of the great barriers to build, that these are sustainable for economic development and promotion of the well-being in the communities and neighboring towns, for infrastructure of a university, and for the healthcare entities throughout the region. And for us, because we now have clinical rotations throughout rural Pennsylvania and throughout the state, not just for Indiana and this region, but for rural regions across the state of Pennsylvania. So this is something that was dreamed up by two brilliant leaders who knew that if we're going to solve some of the problems that we've been having in Pennsylvania for, frankly, decades, that have not been getting any better. In fact, unfortunately, with another hospital closure of OB services, and I'm sure you know well about in the last week, our services and access to healthcare services here in rural regions is not getting better. In fact, the disparities in delivery of healthcare between urban versus rural areas only continues to grow wider in gap. So they were really creative and thinking outside of the box, not just recruiting new physicians and healthcare providers who may come to regions and stay for a few years or leave or not come and stay. They really put their heads together and thought outside of the box around how to solve problems at a different level than which these problems have been created. And it's been an incredible ride to be a part of the leadership group of pulling this off.
Yeah, and you've touched on, the rural crisis, and I think one of the questions is why should we care about rural healthcare? It's that idea of, well, if it's a dispersed population, people choose to live rurally. That one of the things you have to come up with is you don't have everything down the street. Ironically, much quicker for me to get to a Walmart here in Indiana than it is when I was in downtown Pittsburgh area. So some things are easier to access, but
Yes.
I think our closest level 1 trauma center is probably right in downtown Pittsburgh, which is going to be an hour and a half away. Our cancer centers that are known, we have it here now in our Pennsylvania Mountain Health region. We have ability to get that care, but those specialty clinics are a drive, especially for people that are fragile in many ways. And it's quite the shift from, my grandfather was a village doctor. They had no stoplight in the town, and they walked and they brought him baked goods and meat and milk, and that's how they paid for their services.
Yes.
But we don't have that anymore.
Yes.
Everything's kind of been condensed. So why do we care about rural healthcare access crisis? Why should people who aren't rural care about this topic?
Well, at the end of the day, when you look at the demographics and statistics of population distribution, right, on most numbers and accounts, although we often talk about populations as rural, suburban, and urban, they're ultimately on a number of guidelines. Center for Rural PA, for example, will say you've got urban and rural, and that's it, right? So regardless of the numbers and rankings, a majority of not only the statewide population here in Pennsylvania, but in the rest of the country, a majority of our population is rural, right? So we can't say, oh, well, we don't care about a majority of the population within the United States, because that is frankly most of us, right? It's not just you and I doing a podcast talking about rural health. That is a majority of the population actually, in fact, does live rural when you look at maps of the United States. You look at a map of Pennsylvania, we've got Pittsburgh, we've got Philadelphia, and everywhere else is essentially rural to a large degree, right? And that's that piece that you're talking about, where even if something has technically got some suburban, the access looks in some areas identical to the stark outright rural regions. So we're looking at aspects of access to care. And we're also looking at, as you've described, as sort of this country doctor original model that has so dramatically changed. What is in essence through this overhaul of our medical care system, like regardless of administration, right? Like this change has been coming for multiple federal administrations, right? And different people have different approaches, but the overhaul and change back to decades ago, which used to be, hey, let me check your blood pressure, give me some fresh eggs, just bartering and trading and getting back to roots of communities and things like, for example, Indiana, Pennsylvania, like what we are all about and the impact that this has in the communities. That's where it matters, right? Because it's not just, although it is in part, that a majority of our populations are rural. It's not just that even if you live in an urban region, you have family members, people that you care about, and you yourself may end up living in rural regions. And it's not just about access to care, right? It's that at the end of the day, when we look at the changes culturally in medicine, these are trends where the rural versus urban areas are more vulnerable to be hit with the need for healthcare changes, that we're now starting to see some infrastructure and changes and looking at reinvigorating some of these communities. But ultimately, healthcare access is also going to be a challenge for some of these urban counterparts if we don't look at some of the rural models and how these need to start to be changing, right? Because we've got folks who they are using emergency rooms as their primary care. We've seen similar models in urban centers, but that seems to be getting a little bit better with reform and some of the healthcare measures for payments for primary care, but we're starting to see rural getting more and more underserved. So this isn't just about a rural healthcare crisis. This is about a healthcare crisis across the board, where rural is really just that canary in the coal mine, waving the flag saying there's a big problem here because it's more pronounced. But these challenges are going to be a problem everywhere if we don't start to make some changes.
Yeah, and you've mentioned, the PCP component and the idea that a healthy community is a more productive community.
Yeah.
So the ability to do more of those wellness services up front versus and preventative services instead of always just treating at that critical component, whether it's an urgent care or an ED. And I know that's some of the groundwork that's been laid here, which is with a really great residency program that's
Yes.
already kind of
Yes.
rotationally for family medicine. My new PCP is in that program. He's fabulous. He
Yes.
high-fived me over a 6-pound weight loss in 3 months, and I was like,
That's
"Heck, that's
amazing.
nothing." And he was like, "No, that's awesome, like, that's
Yeah.
what we like to see." And I was like,
Yeah.
"Okay, I'm ready, I'm gonna keep up with things."
Yes.
So the ability to have those partnerships between the university, the local medical center, and have a little bit of this foundation of people that have been going through some of those rotations through the residency programs and pieces like that. What are some of the areas that you've had to focus on in building the actual college? So, and I also want to touch on the difference that this is a osteopathic college. So it is different initials after the name, and folks may not care about that, but there are some who do. They're like, oh, a DO versus an MD. Like, what should why does that matter?
Yes.
So tell us a little bit about that formulation of now the academic programming and the DO piece versus the MD piece.
Sure. So, in order to start a medical school, one of the most important things is creating the opportunities for clinical rotations. What's really interesting in getting accredited by the National Medical Accrediting Association for Osteopathic Medical Colleges is that you're not even really allowed to build out an extensive, detailed curriculum for training until you demonstrate that you have clinical rotations. Now, this is a paradox because in traditional medical school training, years 1 and 2 are what are called the preclinical years, where students typically sit in a desk and they look at a lecture and they do case studies. And it's traditionally classroom training those first 2 years. Years 3 and 4, then, after they have that baseline traditional classroom training, they go into clinical rotations and use that applied classroom training to their clinical rotations, where they then enter patient care and enter aspects of being a part of the healthcare system. Now, the irony of having to complete the requirements and have infrastructure set up many years before opening doors for students of having clinical rotations, much before building out the preclinical curriculum is an irony. But we've also seen that that's because for many medical schools and nationally, that there is a shortage of healthcare rotations for healthcare trainees across the nation. So it is not uncommon to have a healthcare training program where students do their classroom training at the school, whether a medical school, whether a PA school, whether a nursing school, and then they do their training in another state outside across the country or in another geographic location to do that clinical training because it's been so hard. Now, we have been very, very fortunate that here at IUP, we have now achieved, the last number was 247% of the minimum required rotations. And the minimum required rotations has some margin. So we take the number of med students that we need to have clinical rotations, and they say take that number of rotations they need and multiply it by 1.2. So you have to have 120% of the required rotations set up so that, if there's changes and infrastructure and you lose some of those rotations, you still have enough margin to have all clinical rotations accounted for and ready so that when students who, by the way, for IUP, they haven't applied it, they haven't matriculated, right? We have to have all those agreements that there will be clinical rotations for our students in all of the specialties that are required for them to have training in their third and fourth years. So we now have 247% of required clinical rotations. We have additional clinics, facilities, hospital networks still coming to us saying we love what you're doing. We're excited about your fresh perspective and we want to be a part of this. We're adding more and more opportunities. And we have now beyond surpassed the minimum benchmark for setting up rotations. That was a huge hurdle for us to pass, and we significantly surpassed it. And that's the one that has often set programs back in their progression towards accreditation. The second area is fundraising, which is something that I think every startup, whether it's an internet startup, starting a laundromat or a restaurant, or a educational program, we need minimum amounts of funding. Some of the funding is for the infrastructure of the programming, paying for faculty, paying for staff, paying for leadership, building buildings, paying for all of the expenses that it requires, paying for application fees. They're incredibly expensive to have some of these application fees for national accreditation. They're expensive because they are the programming and everything that we submit is very carefully vetted by national experts within the industry of medical education. They have very high and strict standards that we have to meet. And then the third area that is very, very important is also staffing. We have to hire the right people to succeed. There are countless movies. I just made a slide from that movie with, I think it was Matt Damon, We Built a Zoo, and I replaced We Built a Zoo with We Built a Med School. I'm like, oh my gosh, we had no idea what we were taking on, right? Just like that movie where they're, this little girl's looking at a peacock in this house that they bought. Like, yeah, we'll take this on. And finding the right people who, just like We Built a Zoo, have that joie de vivre and want to create something and are inspired to be a part of an educational startup, which really is a unique personality. And it's been, it's a very heavy lift and it's a lot of work. And for those of us that are on this team, we are deeply inspired. But it is, it's not just a few hours a week to do that. And so finding the right people who have both the expertise to be able to create the infrastructure that is needed in a very fast time. We have an incredibly skilled team, as well as have the enthusiasm and inspiration to do this work. That's a unique group. And we have been very, very fortunate that people have been coming forward to help be a part of this team that leads the charge. We also have an advisory board with the president that is just a phenomenal group of presidents, chief medical officers, high-ranking executives in healthcare systems, hospital networks, and clinic collaborations that meet with the president and I quarterly to talk about the direction and help form our directions of the college. We also have a steering committee, which is a monthly boots on the ground group that they all volunteer and talk about all different aspects of building the layers of a medical school. So really having the right people and, as second and third layers of support, having clinical infrastructure and community supports. We have had so many incredible supports to pull this off the ground. I mean, there isn't even enough air time to go through how many layers of support that we've had to pull this off on personal, professional, and community-wide levels. It's just been incredible because as we build some of those teams and bring in faculty and bring in administrators and leaders to build this, they need houses to live in, they need services, they need doctors too in this healthcare shortage. And so It's those three main areas that are huge and significant in the main pillars of building the infrastructure for a College of Medicine.
So you mentioned healthcare shortage in general, and I do want
Yeah.
to. We're sitting at a cliff, right? And not just for physicians, but also for nurses. And then we're also seeing this spike in nurse practitioners, in physician assistants. So there's like this new competition for the people that want to get into medicine. What are they going to do? Will they get into nursing and then go forward with CRNAs and nurse anesthetists? Or are they going to jump straight into medical school? So tease apart a little bit of who makes a good doctor of osteopathic medicine. What's the special component about that? And as one yourself, I'm sure you have very
Yeah,
personal kind of
absolutely.
beliefs, but talk
Yeah,
about it.
and I think all of these positions, like being PAs or NPs and these other aspects, those are certain roles for certain personality types and what people are drawn to that provide invaluable care. And typically, particularly in large care teams, a physician will be supervising and signing off on many of these other providers' provision of care. So all teams need all players to work together and work well. The piece that has appealed to me in medicine. And I think for the right people that are drawn to this profession, particularly not just healthcare and communities and healthcare leadership in communities, but to be physicians and healthcare leaders in their communities, which whether or not they signed up for it, as you know from your resident physician, right? Like he or she may not have signed up to be a community leader, but just by being one of the few primary care physicians in the Indiana community area and what they represent, being one of the first few classes of resident physicians in Indiana at IRMC, they've become leaders and people look to them in the community. Similarly, there is an element of leadership, of service that are crucial and essential to being a physician. At the end of the day, we are the last stop. So for services, for availability, we take an oath to protect life, to do no harm, and to preserve and maintain the health of others with the greatest of intentions. And that is a very high oath that many of us have made extensive sacrifices to deliver. There are jokes and have been in the American Medical Association around charting time, which there's a term under chart time when physicians are not only completing their charts, but filling out tasks, and it's called pajama time. And so that time is after you, as the mother or father, have tucked your kids in, read them stories, they've gone to bed. You're still in your PJs, but as a physician, you're finishing your charts, you're finishing your task notes, you're reviewing all the pieces that you need now to practice today as a physician in order to ensure patient care safety and that patient care is managed well. And so that takes a unique person, someone who's going to tuck their kids into bed, and if the work's not done, they're going to go back in their PJs and log on to a computer system to ensure that all of their patient care is addressed and that patient care will be delivered safely. There's also layers of independence. When we talk about some of these teams of providers with varying professional degrees and aspects of supervision, typically MDs and DOs are the final signatory, final approval. NPs in certain practices do have independent practice and ability to do some delivery of care independently and prescribing, but ultimately there are things like controlled substances, higher levels of care, even surgeries that still to this day can only be completed by an MD or an DO, right? Like there aren't NPs who are doing C-sections or even minor right? Like there's still certain aspects that even though some of these specialties can cover an incredible and valuable amount of care, they can't cover all services. And we know from emergency services that the more one individual is able to do in meeting the rural healthcare needs crisis, the better off they're going to be in their ability to help the communities. So it's really a scope of practice that it's a fundamental difference in becoming a physician. And what I have seen time and time again is those that value autonomy, independence, like to have this intricate balance between being a member of a team, but also having their own autonomy, tend to do really well as physicians because they end up often being the leaders of healthcare teams. They're always leading the care of their patients. Even with specialty practice and augmentation of specialty services, your primary care physicians are going to be directing and managing that care. And so it's really an independent and autonomous person that also works concurrently well with teams. That's going to be uniquely well poised to be a physician. Some of the other aspects are just sheer volume of work. I mean, I have been described time and time again as an enthusiastic, energetic person. I am sure that that is a huge part of the reason that I've been successful in getting into medical school and graduating and being board certified in my specialty of choosing. It was a lot of work. It's a huge lift. Even being the founding dean of a medical school, this is not for the faint at heart, and it takes very unique personalities who just kind of lean into stress to say like, yeah, okay, I don't know if I can do this, but like I'm not running away. Like I'm going to lean in, I'm going to feel that edge, and I'm just going to try. And I, like many of my colleagues, have been very fortunate. For better or for worse, the medical care training system does have some ways of trying to weed out those that are not as enthusiastic, do not have quite as much ability to really push through long, huge projects. But it is a part of the training to have that utmost autonomy after years and years of training.
So you've touched on, the personality component a little bit, and I've got it. It's just so front and center because the new episodes have just dropped. The Pit.
Yeah,
You just,
I just
hey,
started to watch those. They're so good.
well, it's so good, and
Yeah,
right here, based in Pittsburgh, and I think it brings. I've heard a lot of people in medicine say it's probably the most accurate depiction that they've seen on television of some of this outside of any reality shows that might be out there showing it. But the component of one, it shows the different tiers, right? The medical student, the resident, the fellow, all those ends. But it also has such a layer of empathy and self-care component, whether it's lacking or it's there, and those people pieces. And I got to pick your brain on it. We see Dr. Robbie going through everything he's gone through and some of the
yeah.
others. What is the piece like? How do physicians take care of themselves when they are the ones that seem to be on the hook so often for saving everyone around them and being that decision maker at the end of the day, where that lands on them ultimately?
Yes, I've watched portions of some of those episodes. Actually, while in a gym on a treadmill, it sort of came up and popped up on the screen. And so, without going into any spoiler alerts of character identification, there's these one series of scenes where a physician, a female physician, we're following her through what is essentially managing a miscarriage and not ending her shifts, right? Because it's clear that there isn't enough coverage or backup coverage, or she's making that choice, right, to stay on shift and also is actively having a miscarriage. And there are elements of that unfortunately or fortunately do ring true. And there are moments that this profession is very much likened to other types of service and leadership where wellness is an important part while also managing what we call professionalism, right? So in military service, if you are leading troops ahead and you have an injury on your foot, if you can't continue to lead and walk and you need to lead troops ahead, you may have your second in command step up, but many will push through if they're able to still walk and maintain that command and lead for the good of the group, right? And so this mentality of being a physician and not ignoring one's current conditions or not ignoring one's wellness, but being able to maintain professionalism and leadership perspective and using that experience to really develop deeper and deeper compassion for others. This doesn't mean like, I recommend personally that if someone's having a miscarriage, like, yeah, get back on shift, right? But we can see so deeply the psyche of that physician and what she was going through and trying to prove herself and demonstrate and maintain leadership and just these intricate balances of managing self and other, because so much of our identities as physicians are tied into doing good work, saving patients' lives, doing beautiful things that change the trajectory of a patient's life so dramatically that we can see impact, especially in psychiatry, but many fields, within hours, days, weeks, or months. And to be able to make those sacrifices without even flinching, that yes, my wellness and my self-care is absolutely important, because if I don't take care of it, it is going to catch up with me. I'm going to have medical problems and I will not be able to continue as a physician. We see that behind the scenes all the time. And yet behind the scenes for us, there is this intricate balance that when we identify who we are deeply in the core, that something is important to us, and these roles as physicians are identity. It's not just for physicians. I understand like military, police force, like we make many physical, mental, and social sacrifices to do the roles that we've chosen to do. And that's because it's a deep life calling. When you feel the call, nothing can get in your way to do what you need to do. And that's one of the beautiful, ironic, and sometimes tragic aspects of what being a physician myself, and I can see is depicted throughout that series and some of these other very popular TV and movie series on being a physician, is that we are choosing, for many of us, a life that has a calling to it, that many of us, often most, will naturally make decisions that in other professions you're just not asked to decide.
Well, and it brings about, an idea, as you mentioned, being so sure of who you are. It's also the idea you're not a doctor to be liked by everyone. You're not going to be liked. You have to deliver some of the most complicated news, not even bad news, but complicated in instances. And so not everyone is going to like you. I always laugh with the 5-star ratings on things because
Yeah,
I'm like, some of the best doctors have been the ones that have told me that I'm a horrible patient. And you know what? They were awesome because I needed told that. I needed, read the riot act a little bit.
right.
But, if they were just there to say, oh, well, Natalie, how can we make you feel better? No, it was you did not follow your care plan. What do you want me to do about it? So, when we think of who should think about going into this type of career, applying to school, like what IUP will have, I think about when you mentioned, hey, this wasn't my first phase. Like this was kind of a secondary
Yeah,
leap that I
a
made.
second career.
I Yeah, I was secondary going into administration on the healthcare side. So it doesn't have to be, it sounds like something that you're like, oh, I got my undergrad. Now I was pre-med. I'm going right in. We're going to do this thing. Like there can be a gap there. It may be a little trickier, like life wise, but that it doesn't rule out that this could still be that calling and you're just realizing it now, right?
Yes, one of the things that, and I often don't talk about this, I don't know if I've ever shared this publicly, but when I worked at a number of the places where I was supervising residents and medical students, I often would just screen and ask who'd been in food service. Because what I found personally is like some of the best training I had in being a doctor was working the graveyard shift at Denny's. I don't even know, like I've seen like one Denny's since I wrote, right? But like working in these like diners where 2 a.m. some guy, like, he's going to pay you in quarters if you're lucky, right? And he's yelling, and like back, this was when they're smoking sectors, yelling and smoking, and these French fries you got to reheat the food, and these are some very interesting, challenging individuals to work with, and yet we still have a role to serve them food, to get folks as in and out as quickly as we can, to try to make and earn a living through tips and getting as close to what the customers want so that they can enjoy their meals. Many times they do. It's always the occasional interesting individuals that are just so memorable, and learning how to deal with that whole just range of different experiences and still try to get people the experience that they are there for, that you're hoping they'll be getting through, in a restaurant experience. I can't tell you how many times I've seen that folks who are really good waitresses or baristas just kind of knew how to work some of the situations that were incredibly challenging in patient care. There's a lot of similarities of just knowing how to approach different personalities and stressful times that have tied over. One of the big indicators is not so much the scores and grades. Above a minimum standard of scores and grades and minimum aptitude of scholarly activity, what I have seen time and time again is that the key indicating factors, once someone can overcome the minimum standards, has been a growth factor. So I've seen students that they just looked amazing. Their scores, their grades, their letters of rec, they came in. I was blown away by some of these students coming in, looking at them on paper. And then I've watched them progress over the years. And those that did not have a growth mindset, who were just used to being number one in their class, doing so well in everything they touched, all of a sudden would have challenges, right? Because this is a whole nother level of volumes of information that one needs to know, memorize, integrate, and apply. Those that thought that they would do so well and weren't able to pivot and shift to try to learn new tools, develop new skills. It's really a growth mindset. They often had some of the greatest challenges, right? Because maybe they would barely pass or become more mediocre, but psychologically they really suffered. Versus some of our students that they kind of barely got into medical school. Their grades were okay. Their scores were good enough. We thought like they're probably going to pass. Like we may need to do some extra prayers there, but we think these students are going to pass, right? But if they had a growth mindset, they were so able to quickly pivot that we saw over time, those students, by the time they hit clinical rotations, they absolutely excelled. So one of the factors that we see that is not about numbers, scores, and grades, that, interestingly, going back to this restaurant and server, being a waitress example, is having a growth mindset and ability to adapt, shift, and change with an openness, not about I'm going to get it right and be perfect from day one. And if I don't get it perfect and I'm not right, then I'm going to fight to be perfect and right, right? Instead of just like an openness of, okay, let's see what shows up. How am I going to pivot to make this situation work? So that doing well isn't necessarily about the endpoint and outcome, but about the process towards success. And we've seen time and time again that the more students who have a natural growth mindset or can learn a growth oriented mindset, those tend to excel. If we can just get them into the medical training that they choose to be in, we can often help them excel if they have that mindset. I've seen that in sports. I've seen that in with medical students. I've seen that with physicians in practice. I've seen that in leadership trainings. The growth mindset seems to be one of the very big, most important aspects.
So, what are some of the suggestions or ways that you have? Because one of the barriers is cost, right? To get
Mhm.
in this. So, someone's listening, they're like, yeah, I got that. Like, I've been 5 years in, I've got that. Like, this sounds like me, but there's no way I can not have a full time job and still, fund what I need to in life. I still have my loans from previously. So, what are some of those ways that you or the admissions group or in the past have worked with students who could be the very best candidates out there, but just don't have the opportunities or the funds to be able to do this with ease, I should say, because we know there's loans and things like that, but it's still a lot of pressure in today's world.
Yeah. So there are a lot of opportunities, and the easiest, which I did not follow, but the easiest is to get your pre-medical classes through your undergraduate degree as you're pursuing. And we have so many students now. My daughter went to the Indiana area high school, and she did college classes, and I understand now there's students entering college, they graduate with so many college credits that then you can go in, and even if you're not a pre-medical or sciences major, you can get those pre-medical classes in and on board, especially if you have additional credit. So that's certainly the easiest track because it's a part of what you're already doing. For me, I did not take that route. I had absolutely no idea that I was pre-medical when I was in an undergraduate degree studying psychology. So I went back and I took night classes. It was a heavy lift to have both a career and take classes at night. I also invested well in some property and was able to refinance that property, help pay for it. Had some very fortunate, serendipitous, probably not so serendipitous bumps along the way that put me in the right direction. I have worked with many students who do the same. They just work, and any extra amount of money that they have, they just put it into taking night classes, and they slowly took night classes over years. I did that for a couple of years, and then was able to refinance a home that I had invested in like in my 20s, and like went back to school full time with the money that I had made, and then ended up selling the property and made even more money, and just kind of used that funding to fold back into myself and invested in myself to go back to school full time, and also studied full time for the MCATs, and did some things like that. The other opportunities for students who are working are these graduate degrees or like a master's in biomedical sciences. IUP currently does not have one. We have been talking about the possibility of having them, but almost every medical school has a master's in biomedical sciences, which is minus one or two prerequisites depending on the program, a way to get all of your pre-medical requirements into one master's degree. Depending on the school and program, it's anything from a 10 to 18-month program. And the additional opportunity in that is that by enrolling in full-time classes, you would then have opportunities for financial aid, right? This piece on debt, this is a big question that we are discussing with several legislators, funders, folks across the state of if we want to solve the rural healthcare crisis, we are going to have to look at affordability and cost. I and leadership at IUP are deeply devoted to making medical education affordable within the state of Pennsylvania and accessible to our Pennsylvania statewide constituents. And so there are going to be some different models that we're currently sort of pressure testing and mapping out, haven't made public or official at this point in time, but we as an institution are very devoted to that. IUP is a statewide system. As an extension of the Commonwealth, our motivation is to make enough money to be net positive and be financially healthy, but it's not to make as much money as possible to fold into itself, right? We really have a mission of serving a workforce fulfillment rather than financial goals. being sustainable and responsible. So there are these master's programs that one can also enter, that if someone's kind of shadowing a few clinicians or feeling this out and they decide, no, like this is what I want to do, they can do that deeper dive and do some a master's program and do some research into the many, many programs where one could do that.
And there's lots of resources too, if folks are interested and don't know where to start, to actually reach out to the schools
Yes.
and ask those questions, right? So I always say we don't use our counselors and our admissions people nearly enough to be
Yeah.
like, tell me how I do this. But that's what they're there for. So definitely a shout out to that. But one more kind of context based question that I got, one softball to throw at you at the end here before we talk about how people can reach out to you. But, back to the very start of the conversation, you mentioned the socioeconomic differences. We talked about some of the access to healthcare. How are we going to create a next generation of physicians that are good people at looking at that bigger population health picture? So not just what's my specialty area, but the fact that this isn't just OBGYN, this is OBGYN to someone who's going home to limited food in their refrigerator, or they have no backup care in the home to help them out and they've had a C-section, or, all of those different pieces that are that whole health model. I guess academically, how are we looking at building that out further? And what do those supports look like as they're going through rotations or building those expectations of this is part of the gig now? It's not just that person, it's that person within their system.
Yes. So, one of the pieces that we're working on in the background, especially in terms of our anticipated future recruitment of potential medical students here at IUP, is looking at some of the infrastructure. And I don't just mean infrastructure IUP, infrastructure of the entire healthcare system, of who we recruit, what we attract, what that requires, and then assuming we'll get different endpoints, right? So intrinsic versus extrinsic values. So extrinsic values are things theoretically like great amounts of money, like fortune, like not just like making good money, but like really, really good, like fortune, fame, like public, like you talked about, like being liked, right? Like public fame, acquisition of items and things. So like collecting, the traditional photos of, like 30 cars and building a large garage just to hold all your collection of cars, and then the expense, right? And so one of the things we're looking at is the opposite end of that model, which is intrinsic values, right? Which is connection, relationships, inner happiness, joy. Right? You look at the people that are oriented towards those types of intrinsic values versus extrinsic values. And we can recruit with those values in mind. Right? And so we have a system right now that paradoxically, even though it's a healthcare system, financially only survives by keeping people in a disease state. It financially only survives as a healthcare system by billing, by keeping people in a diseased state. And then even more paradoxically, we pay for health insurance that we often have to fight. And sometimes the providers, we as physicians and the people writing the prescriptions, are often fighting the hardest to get that insurance coverage to manage the disease state for the prescriptions and the services, right? And this is something that you've already experienced. Whereas if we have an intrinsic-based system with starting a new stream of future learners and generations, that just like that resident physician, I think I actually even know who that might be, right? Who gave you a high five, but I'm sure just about any of them would high five you, right? They're not there to collect cars and have their faces in the paper. I mean, a couple of them have already had their faces in the paper, right? But they're there for that moment that you had when you gave the high five. Because one of the greatest deficiencies that I have seen in healthcare, particularly as a psychiatrist, is, it's not the pharmaceuticals. It's not, it's the deficiency of connection. And once we lose connection, that begins to deteriorate our connection to all of humanity. It's a deficiency of hope. It's a deficiency of connection to others. And those that are intrinsically motivated naturally are drawn to that. So we flip the system rather than pre-gaming it towards what tends to probably not intentionally attract extrinsically motivated individuals, but extrinsically motivated individuals often will be recruited and drawn to this profession, right? And then they go through this huge crunch of, oh my gosh, I was attracted to this right, to do good, but also for these other reasons, with all the debt and the loans, these things aren't happening, right? Then you get widespread physician burnout. And, I've worked with countless physicians and clinicians, especially in rural areas, that interestingly, Natalie, they're more on that intrinsic end. I mean, go through IRMC or Punxsutawney Hospital and find me one physician that doesn't have a preponderance of intrinsic motivations, right? They'll stop you in the hospital like, hey, are you Dr. Rose? Even if they don't know who I am, how you do, right? And so we just need to take the model that already predominantly exists in rural areas and replicate that and do that intentionally. So we're creating an intentional workforce stream that you and I already see in the rural regions where we live and where we visit, to create more doctors like that. I don't have to recreate the wheel. We already know successful physicians that we want to see more of. We just have to give them additional support with more clinicians around them that are graduating, so that we have better ratios of students graduating who really want to do this work.
And I am a firm believer that the more physicians we create like that, the more that outside pressure on the system itself, which I fully believe is very broken,
Yes.
uh, will force change, right? We already see it with the concierge medicine model kicking up. We already see some of those pieces that this isn't sustainable long term. We have to make change, and good people doing good work is who's going to lead a lot of that change.
Yes.
So as we get towards the end here, I have to ask, I saw in one of the write-ups that you did that you are a reality TV person.
Big TV fan. It's because I'm a psychiatrist, right? I love watching humans being human because we're all so human. Yeah. Yeah.
So I got to ask, what's your watch of the moment right now?
Oh
With
gosh,
all this extra time you have?
yeah, it's not right. It's like in these bits and spurts. So I will also mention I'm a big avid puzzler. So I just picked up a
Very
really nice
nice.
Ravensburger that I've been working on for the last few nights. Um, I've got to say, at the end of the day, I've had a lot of stints in reality TV and kind of going on some dives of a couple different shows. I've seen them all. Well, a lot of them. I think right now my favorite is Bravo and the Real Housewives of Salt Lake City. Right? Like, in the spirit of full confessional, I was a VPR Vanderpump Rules fan, and then they changed everyone, and it's just, I was used to watching the old guard. So now I've become a big Salt Lake City fan. There's just something about watching all these individuals with a lot of resources trying to self-regulate in their homes as they travel in their careers that it's kind of amazing. It's kind of amazing. Psychiatry never leaves me. The profession chose me, and I just never left. So. Yeah.
Well, and I saw someone saying that specific location has this extra layer of the impact of fundamental religion
Yeah.
on some of those characters. So
Yeah.
even that, like, it spices it up just even
Yeah.
an extra level. We're like, okay,
Yes.
what traumas
Yes,
does
like
this tie
cultural
back
and
to?
political differences, and how do
Right.
people still find the common themes? I mean, I feel like we here in Indiana and throughout rural Pennsylvania, right? It's the constant conversations
Mhm.
of people coming together with different views, with different politics, with different backgrounds, with different cultural beliefs, and
Mhm.
finding that common ground so that we can be together in communities and have those difficult conversations. I personally think, with a whole lot of bias, having been here for just over 2 years, that that's something we do here in Indiana really, really well. Yeah.
And it is, you can walk down the street and you kind of just feel slight changes, and like where people have even
Yeah.
nested right in this borough itself. And having the university here, I think, mixes things up very interestingly compared to a very similar town like Indiana that doesn't have a university situated in the middle of it. So just fantastic socio dynamics of everything. So we're getting to the end here. I want to make sure that people know how to find out more information about the IUP, College of Osteopathic Medicine,
Yes.
about everything we're working towards. So we'll make sure it's all linked. But tell us a little bit about where they can go to find out what's the exact new happenings that are going on, the timelines around this, and everything like that.
Yes. So we are, in the next couple of months, going to be shifting over the web pages to be independently housed under our own college. Right now, it's under the president's webpage at IUP. And we are looking to matriculate students in 2027, which means we could be able to start recruiting as early as May or June of this year. So in just 4 to 5 short months, we will be potentially opening our doors and starting to accept applications.
It's incredible.
Yeah.
And I think too, if people, there are people out there that want to be part of something very inaugural.
Yeah.
So I'm sure that'll be super
Yes.
interesting. I can't say enough. The people in this area to treat them. So if you were going to come here and do clinical rotations, it's it's really interesting. I mean,
Yeah.
it is. And
Yeah.
so you don't have to be in an inner city, high academic medical center to see really unique individuals, all kind of different things. The diseases exist everywhere. The personalities exist everywhere. So you get the same kind of mix of patients that you see. But, I am just really thankful and grateful to have been at the Rural Health Symposium, heard about
Yes.
all of these things coming
Yeah.
forward, and that you jumped on the opportunity to come in here and chat a little bit about this. And hopefully, we'll be in a year from now doing a follow up going, all right, so
Yes.
how's things going? How are we,
Yeah.
getting into everything? But Dr. Rose, thank you so much. Is there anything you'd like to leave everyone with as kind of a closing note, closing message that you hope they take away from our chat that we've had today?
I think you and I talked a lot about, being DOs in osteopathic medicine and following the needs of the community and rural health and all these elements. I think at the end of the day, the big picture is to find something that inspires you, even if it doesn't make sense, and do more of that. Because for me, it ended up being medicine. And this is a second career. That was a great surprise to me. And I just followed my passions and the things that gave me joy. Many of those things were surprising. And I've followed that road and it's been incredible. And the types of students that we will be looking for when we recruit are those who are passionate and inspired. But even for your listeners who are like, that's awesome, and I've absolutely no interest in pursuing medicine or becoming a physician as a career, that is also amazing. And I think that we have been just so incredibly lucky to have so much support. And I want to thank all the listeners and those who already know about the comm and have supported us in the many ways. I want to thank everyone for their incredible support. This has just been an amazing project, as you've seen. And for folks who are interested, yes, we'll send you some links to make sure that you get the links and updated materials on our websites and ways to reach out and help.
Yeah, and it really does fall into that. Hey, you never know what hot mess will end up as a high potential. Podcasting wasn't on my idea, and this is just my little hobby on the side, but I love it. And I think
Yeah.
giving it back to, know what fills your cup, and it'll make sense as you get into it. So,
Yeah.
Dr. Rose, thank you so much
Thank
for joining
you. Thanks for
Motivation
having
Aloud,
me.
and we will talk again soon.